Richard, shoulder straight.
Right, let's do it. Let's hear it for Richard.
Hello, welcome. I thought I'd briefly start with this slide. It's really just for me, it's not really for any of you, but it's because I have a fairly unhealthy obsession with the concept of irrational fears. And I'm linking that to public speaking, and in acknowledging that fear, I thought I'd start with this slide. And then over the last couple of days, I was having to think about why am I so anxious given what I do for work. I'm a paramedic. I don't get anxious at work. I do get anxious as soon as I have to speak in somewhere. And so I thought about this, and I've written some notes. It's entitled, Why Am I So Anxious, especially given what I do for a living? And I've decided it's because of the previous presentations. They were so good. They were so good. So if we start with day one, Tim, cardiothoracic surgery, initiating improvements in a patient group that I know absolutely nothing about. Pete, you worked Kit Kats and their value in Japanese culture into a presentation. I am in awe. You also mentioned the famous gorilla task where our biased perception, and I've tried to work some of that into this presentation. Matt, inspired. I saw you here earlier. That's inspired. Brother, I want to be like you. When I grow up, I want to be like you. Yeah. Day two, Simon, orthopod, working with NOFs over in Perth. Links well with what I'm going to be talking about. If none of you have read the program, then you don't know what I'm talking about, so that's good. Mark, speaking to PED communication and constipation. I can confirm you've ruined toothpaste for me and brushing my teeth. And then finally, Indy, some practical approaches with PEs that I really enjoyed with our continuum of care concepts in terms of what we're all involved with. So let's get into it. Again, briefly, thank you. Why am I here? Well, I did a thing, and I wanted to tell everyone about it. I produced this publication as part of a Masters in Critical Care with Monash entitled Out of Hospital Neck and Femur Fracture. It was an 8-year observational study. I think I should probably point to the team first there, where you see Z and M. They're out of the Centre of Research for Evaluation in Ambulance, Victoria. Becomes important later. Brendan Schultze, he's involved in the guideline development with QAS, it's Queensland Ambulance Service, which I also work for. You often hear stories about really, really bad honours and masters experiences. I didn't have that. This was a fantastic team. And then there's me there, Richard. I'm just currently working on road as an ACP2. I am like low level, just your standard paramedic. There is nothing special about what I do or where I am, out of Met South. A list of things to come because I like structure and order. So I thought I'd give this a bit of context. The patient experience, so just a brief case study. It won't be anything serious. Then we'll go through the research, some of the objectives, why we thought it was important, what we did, how we did it, and what we found. And then the next step, I was hoping to get some of your experiences and some of your thoughts wrapped around a little bit of research as well, followed by some questions at the end. So the case study, paramedics in the room will know that you called to a 6 o'clock in the morning, 80-year-old female, fallen from bed, now unable to mobilise. You find her on the floor. Your nearest tertiary institution is 2.5 hours away. Patient's still on the ground when you get there. Significant pain and discomfort, so it's very obvious that she's not doing so well, but her ABCs are intact, so she's stable at the moment. Pain is worse on movement and palpation. Head to toe reveals some obvious shortening and rotation of the right leg. Past medical history suggestive of osteoarthritis, falls, fractures and chronic pain, and the meds tends to back that up with a shopping list of opioids. So it won't come of any surprise to people that our clinical impression is going to be a NOF at this stage, post that fall from bed. This one has a bit of a personal experience for me because this was my grandmother in 2020, and she was treated well. She was living in New South Wales at the time, treated by New South Wales paramedics. Don't need to spend too much time on the next couple of slides given the room, but the neck and femur fracture I've tried to depict there, associated with some pretty horrible outcomes for the patient, especially in our elderly population, also associated with some pretty extreme pain. Not going to spend too much time on this one either, because we all know the verbal numerical rating scale 1 to 10, but you can also consider pain as being rated as mild, moderate, severe. That will matter shortly. And more importantly, the clinical meaningful pain reduction. So a pain score that is at least 2 points reduced is what we call a clinical meaningful pain reduction. And that's fairly standardised across the literature. I've also got the Wong-Baker phases rating pace just up there for our non-verbals and our PEDS. I've decided to use or just briefly go through the Ambulance Victoria CPG at this stage, just given where the research came from, despite the fact I'm probably more familiar with the Queensland Ambulance CPG. So currently 4 recommendations. The first 3, no surprises, hemorrhage control, splinting practices, often quite difficult in my experience. Often we're just positioning for comfort. And of course resolving neuro and vascular compromise. And point 4, which is the one I really want to talk about, which is the judicious use of analgesia. So ranging from the simple analgesia, the paracetamols, ibuprofens, into the inhaled anaesthetics, methoxy, opioids, morphine, fentanyl. Interestingly, fentanyl was introduced in AV protocols in 2015. Morphine is considered the gold standard. And then the dissociative agents, ketamine, introduced in 2020. So why we thought that this was important, most of the research points to the etiology, mostly falls in our elderly populations, often associated with high mortality rates, and a sequelae of injury. These patients often really don't do particularly well. Pain management, won't be a surprise, is actually a central priority for EMS. That's all state-based services. And then with a good understanding of the experience of pain is complex and extremely multi-dimensional. So it's really quite a complex problem. But we do know that early analgesic options often lead to improved rehabilitation and recovery in most patients. So as I mentioned, currently systemic analgesia, morphine is currently probably considered the gold standard. So looking at the actual study that we conducted, briefly the setting, so Victoria, those who don't know Australia particularly well, about 6.5 million people, majority of whom reside in Melbourne. Ambulance Victoria is actually a single EMS that responds, but it's dual-tiered services. So you've got the advanced life support like myself, and then you've got the intensive care, which have a slightly expanded scope. We conducted a retrospective analysis of the EPCR, so that's the document that they produce at the end of every job. Patients presenting with NOF injuries that were transported to a hospital by EMS within the Victorian state. All of these cases occurred over an 8-year period between July 2015 and June 2023, and we used a multivariate logistic regression to examine the factors associated first with that clinical meaningful pain reduction of 0.2, and then with the moderate to severe pain upon the final assessment. Just speaking to the graph that I'm hoping you guys can see. So initially you can see the number of ambulance attendances is a tad over 5 million. We included patients of just under 16,000 patients that were confirmed or treated for a NOF in the out-of-hospital setting. So a significant number. What we actually set out to do, so outcomes of interest, obviously we want to look at the characteristics of this patient cohort that we were interested in. Our primary outcome, again, that clinical meaningful pain reduction of 0.2, and our secondary, all those patients with intractable moderate to severe pain. So moderate to severe, anything equal or greater than 4. Our results. Now, I thought about this one fairly carefully. I pulled these directly from the paper, mostly so that you know they're real. And also because they represent a significant portion of my life. I've so many hours you sit there and fiddle with these sorts of things, but they're boring in presentations because they take a bit of time to read. So I've dot pointed it. This is all the important bits that I want to talk about now. So the characteristics, mostly female, 70%. We had a median age of 84, so elderly. The most common mechanism, if we refer back to the case study at the beginning, was actually just a fall, low mech, often from standing height. Overall, however, that is a really, really nice figure. 82% of patients achieved a clinically meaningful pain reduction upon their conclusion of their out-of-hospital episode with Ambulance Victoria and our paramedics in a notoriously difficult sector. So it's really well understood that we don't do particularly well in analgesic options out of hospital. We also found some contrasting findings within the literature. So the bimodal incidence, we didn't see that in our data. So often we see a group, usually younger males involved in high mech, that often have this type of injury, and then a second group, usually older, with the associated falls. We didn't find that one. And also we didn't find that sex was an influence on the clinical meaningful pain reduction either, which is another one that was a little bit outstanding for us. However, 82%, while it's good, it did leave 1/3, just over 30% of the patients included in our study had a final pain score of equal or greater than 4. So it's still in significant pain. Further, we also found there was an increasing trend in the proportion of patients with that final pain score. So I guess that led to the natural question of what our options are available. Does anyone have any ideas of where I think I might be going with this in terms of interventions? I can hear murmurs, yeah.
CCP intervention with ketamine?
I think they've got it.
Using it?
You went for
we
Queensland.
never called CCPs, but should we?
And New South Wales alcohol and ICP use it very liberally.
So, yeah, well, that one works because my grandmother did get opioids, they didn't work. She was transported, but she didn't get ketamine. Maybe that would have worked better, I'm not sure. But here's where I was thinking. I want to know whether or not peripheral nerve blocks could be used in the out-of-hospital setting. And given the quality and quantity of people in the room, we'll probably have an answer to that question. I feel like this is a good start. Just so we're all working on the same definition, that's injecting a local anaesthetic around the nerves to block and stop that sensation of pain. It's routinely used in hospital and is considered safe and effective. Scattered literature though, in the out-of-hospital environment. Very, very scattered. And this is probably the next bit of it. I'm partway through producing this to publish. I've had a look at or done some sort of a version of a systematic review, identified 1,044 different articles across a couple of databases, and in this particular instance I've only included 16, and this is what we found so far. I think I've broken it up into how the block was used by injury chest. Our particular interest is obviously going to be hip and femur in this particular instance, but also the quality. I've done a brief quality assessment down the side there, the type of block that was used, whether or not it was pre-hospital or aeromedical, because they're a bit different, and also where it is. You'll note that Australia is actually representing quite a lot in that particular table. So if we zoom in just a little bit further, this is the articles that were identified. There's one that I did contact the authors, but they didn't get back to me because it wasn't clear whether or not it was actually out of hospital, so that one's not in here. But again, looking at the adverse outcomes of the safety focus, of course, success rate, which was really quite high, the type of technique and the type of agent that was used, and whether or not there were any other agents on board, so any kind of multimodal analgesic options. And you'll note that it really does look kind of pretty clean. There's Jones down there with the hip injury with the local tox. That was reversed with intralipid. But, and a couple of nauseas reported in one other study, with no other adverse outcomes were reported. A couple of changes across there with the different agents that were used. So this is what I mean by scattered literature. There's absolutely no consistency on what was used, how it was used, when it was used. So it's kind of difficult to draw any particular conclusions. I've only ever been involved in one, because I'm just a paramedic. We used a bolus dose of ropivacaine. It was very effective on a 74-year-old that we were trying to fly back to Transport Road, transport back to Mackay Base. So just having a look at the summary of what I've actually said. On the background of that case study that was my grandmother, I want to acknowledge that AV is demonstrating some seriously cool improvements in that out-of-hospital analgesic area. However, we do have 30% of this cohort that remains in moderate to severe pain. And I want to argue that the future direction is going to be in our out-of-hospital nerve blocks, and that there is some literature out there. And now I want to ask the room for their thoughts. Do you think it can be done? Have I reached too far? Would you let a paramedic do it to you or your family? That sort of thing.
I probably don't need the microphone.
You're fine.
So I'm an anaesthetist in Brisbane, and what I would say is a bit like every other thing. If you do one a year, you'll probably be scared to do that one and then not do it. But if you're doing a few, it's an easy technique. There's a few, the 3-in-1 block or the fascially arca blocks, both pretty simple, very effective, low risk, and I would say it'd probably be easy to introduce and do. And if you're seeing a lot of these, I would have thought a subgroup of paramedics would get very skillful very quickly.
So if I would add to that, you've got about 200,000 nationally every year. And I think Queensland Ambulance, the last data I saw was more et al. I think that came from 21, and they quoted 42,000 queried NOFs in Queensland alone. Would that give you enough numbers?
Sounds pretty good.
Sounds pretty good.
How do the paramedics feel about it? 'Cause I'm an ED doctor, and that sounds amazing. Like, if the paramedics are going to do a fib in the field, that makes our job a whole lot easier, and makes the patient's experience potentially a lot better. What's your experience been with getting EMS systems to get this on board?
I think getting the organisations to give us the training would probably be the hardest part. I don't know a paramedic that wouldn't give this a smash, but we're all a little bit overconfident. We would need some guidance. Of that I can assure you.
In Queensland, they give it to the CCPs first anyway, right?
Yeah.
2-3 years, see if there are any negative outcomes, and then potentially roll it out to ACPs. But I never call the CCP for ketamine in an off situation, because I don't think they give it on the Gold Coast anyway.
No, they don't.
There's another question on the back.
I'm just wondering about your ultrasound usage as paramedics. So I'm in a rural ED, and we live in routinely as a rural generalist. So where are you guys at with your ultrasound? And once you've got your ultrasound skills, it's really easy, as the anaesthetist one said.
I think I've got an answer for this one, and that is that our Haru and all of our medical officers have ultrasound. In fact, I even did a job with Steve Rashford where it fell off the back of his car. So maybe just one less ultrasound.
The current studies at the moment showing the use of nerve blocks, are they predominantly in retrieval settings in rural and remote places, or are they in metro areas as well?
Within the Australian studies, yes, predominantly sort of this retrieval, long haul, rather than filling them up with systemic analgesia, we're giving them another option. And I think it's then been guided by consultants. But there are some other studies out of Sweden, some of those places that are a bit larger, and they're not. They're actually within much more metropolitan areas.
Could you see that a patient with a pain score of 0 would be ramped for longer at a hospital with a knock than one who's got uncontrolled pain?
The question was, do I think that a patient would be ramped if with a pain score of 0? I've got no idea. I can't even work out how ramping works half the time. I get ramped with resus patients, where I think we should be.
Can I just speak on that one from the Gold Coast perspective? We've got a main hospital that does, from the Gold Coast, we've got a main hospital that does all of our NOFs, and they are higher prioritised than
sort of mechanism of the injury as well as all the other vascular compromise that can be part of it. So they do have Cat 2 normally when we take them in.
I think it depends on which hospital you went to. A Cat 2 can wait a pretty long time in Brisbane, depending on the day. I know they do well, and I know the system's bigger and harder for me to understand, but yeah.
During your literature review, did you find any significant sort of strong sort of evidence risk-wise, ultrasound guided versus landmark method for femoral nerve blocks?
No, you wouldn't be able to easily distinguish because it's so scattered and the procedures are so different and they use different agents and so I wouldn't be able to speak to that. But I would love to see a more proper randomised control trial that could actually answer that question.
And I can throw a little bit of light on that. I'm in a privileged position of starting my career before ultrasounds were widespread, and we all just learned the technique, and we were told this is the one you can't mess up. I would not let ultrasound be the reason you didn't put this in an ambulance setting. If there was another reason, so be it, but I wouldn't let lack of ultrasound be that reason, because I don't think it's easy to teach, it's easy to do, the risks are extraordinarily low, ultrasound versus not. And I reckon if you're going to stuff it up without an ultrasound, that same person will stuff it up with an ultrasound.
I think if I could add to that as well, like we lie to people. So we're giving a drug that kills almost definitely 1% of the people that we give it to, and yet we don't have this, or we haven't explored this properly as an option. I don't know whether or not it creates a bit of context for anyone.
We've got a question right at the back, making it work.
Not a question, just I want to second that point. I'm a rural facer in Queensland, and I teach the landmark technique to all my residents going out west doing rural relief because it's reproducible. You don't need ultrasound. You just need the drug and a needle.
Do they have the budget to put a $5,000 device in every ambulance, and would the case be better made if you had other procedures that ultrasound would be useful for, that you could train a bunch of paramedics to do, and would that be too much of a departure from the role of the currently seen role of paramedics, and maybe this is the beginning of an evolution?
I got multiple answers for this. The diplomatic one is I've got no idea, not really. The other one is I don't really care, they should just do it. We spend so much money on so many other aspects of healthcare, we can't throw a little bit of that, I don't know. Is that recorded? Am I in trouble? Probably.
Any other questions, comments? Brilliant. Well,
I haven't finished just yet. So the gorilla aspect, I incorporated antidotophobia, the fear that somewhere, somehow a duck is watching. If you were looking carefully enough, you saw there were ducks on multiple of the screens, and I just like that because it's funny. That's my LinkedIn. If anyone wants to find me, I don't know, do so. Cheers.
excellent. Let's hear it from Richard.